Welcome to Connected by Health. I'm Dr. Krishna Vedala. This is where medicine meets leadership, innovation, and humanity with one goal: to add value and help change healthcare for the better. If you believe health is about more than a diagnosis, you're in the right place.
All right. So today we're joined by Dr. Megan Sheppard, a board-certified bariatric and foregut surgeon specializing in bariatric surgery and also minimally invasive techniques and also complex foregut procedures of the esophagus and stomach. Over the years, Dr. Sheppard has helped many patients safely transform their health and lives. And today we'll discuss the latest advances in bariatric and foregut surgery and also practical guidance for patients considering weight loss or foregut procedures. And Dr. Sheppard, thank you so much for coming on today and answering our questions. Could you please tell us a little bit about yourself and what made you want to go into bariatric and foregut surgery?
Yeah. Well, I just want to say first, thanks for inviting me. I'm so happy to be here and be able to chat with you about this, and hopefully someone will learn something new and help change their lives with this. I am originally from Wichita, Kansas, so just up the road. I went to KU for medical school, and then I went out to Knoxville, Tennessee to do my surgical residency, and then finished my fellowship coming back here to Kansas City. And we did advanced general surgery along with bariatrics, foregut, advanced endoscopy, and we did a lot of revisional stuff, which is what brought me to my fellowship in Kansas City, so I could learn a lot about that. The reason I really got into bariatric surgery is always I
Mm-hmm.
struggle with her weight all of her life. She would diet, she would lose a bunch of weight, and then as I've learned now, the body compensates and it just doesn't allow you to keep that going for the most part. And so she ended up having a sleeve and lost a ton of weight and now is playing pickleball and does a bunch of stuff and ended up actually getting really bad reflux from her sleeve and got converted to a bypass. That's really what brought me to it, to see her life change from when I knew her as a kid versus what she's able to do with my kids and her grandkids. She's so much more active and does so many different things and really has blossomed, not just from a, weight standpoint, but also just socially. The impacts of what we see with obesity and what that takes on a patient can change dramatically with these surgeries. And so that's what really brought me to go down this pathway.
Wow. Well, that's amazing. I didn't know that you had such a personal experience involving your mother, especially with bariatric surgery. You know, you specialize in endoscopic sleeve gastrectomies, and so for patients that are unfamiliar with it, would you be able to explain what that is and how it differentiates from the typical sleeve gastrectomy?
Yeah, of course. So this is a new procedure just recently recognized by the ASMBS. So although it's been around for a little while but it's really starting to come on its own at this point. So what I use is a camera and I go down your mouth with an endoscope like doing an EGD. And then I actually sew the stomach from the inside using the endoscope. So no incisions on the outside. And I kind of involute the stomach on itself so that we're decreasing the volume of the stomach by about 70 to 80%. So we're not removing anything from the body like when we do it surgically. Everything kind of gets folded in on itself and you get no incisions on the outside. Generally, this is done as an outpatient procedure. So people come in and then go home the same day, which a lot of people love. They don't have to stick around the hospital, but that's kind of how this works. So it's kind of nice that people don't have incisions. They get to go home. Really, you're
Mhm.
up and moving. The worst part is the diet for this. I will say that you do have to do liquids for quite a bit of time to allow these sutures to heal. But
Okay.
after that, it still has pretty good results.
If you don't mind me asking, how long do you have to do the liquid diet for?
I make patients do about liquid diet for about 4 weeks after this, really allowing that stomach to heal and scar down. If you start eating a little bit more, I mean, you still can do things like yogurt and pudding, and so I do full liquids. But otherwise, if you're stretching out those stitches and they haven't really gotten a good chance to heal and kind of involve on itself, then there's a good chance that you could rip it open. You're not going to
Mm.
get the desired effect and the weight loss from it.
will they still have any of the typical, adverse effects that we typically see with the non-endoscopic sleep gastrectomy, like specifically when it comes to B12 deficiency, any other kind of vitamin deficiencies?
I don't really see a lot of deficiencies with these because of the stomach
Mhm.
is still there. You can still get some of those nutrients through, and even with the sleeve in general, a lot of those patients don't have a lot of nutritional deficiencies. It's more about just not being able to get as much food in, and there's something about I don't know that we really know, removing that part of the stomach or involving it, involuting it, changing those hormones that really control your satiety and those kind of things. And we don't see as much reflux with the endoscopic sleeve, but that's a nice piece of it because they
Mhm.
still have that fundus. I can't
Mhm.
get all of that up there sewed in just from the nature of how we do the suturing. I can't kind of look back up and suture from the inside, but we tend to see they don't have as bad a reflux as some of the other people do.
Wow, that's amazing. That's a big deal right there, because I do know that some of my patients that have had sleep apnectomies, they do deal with a lot of reflux, but that's a good catch right there. When it comes to the candidates for, and I'll just call it ESG, just because I can't say the word too many times. But for the ESG, is there any specific criteria for candidates, or is it just anybody like your typical sleep gastrectomy?
We want patients to have a BMI of 30 to 50, so still about the same as you would with a vertical sleeve. The big thing is you can't have a hiatal hernia. You could have like a very small one, but I don't want to be suturing in your chest and
Mhm.
grab your lungs or your heart. So we don't want you to have a very big hiatal hernia. And still with a sleeve, although it's not as bad of reflux as the a surgical sleeve, I still don't want you to have terrible people that have rip roaring reflux. This is really not the surgery for you. We really need to fit them towards a bypass as a treatment for reflux. But otherwise, it should be a good option for patients. And I think just talking with your surgeon, talking with, even your bariatrician or whoever about what you're wanting to get out of the surgery or out of these options. Is it just weight loss? Is it that you want to get off medications? What are you looking for so we can find the right procedure for you?
Mhm. So does it does the ESG actually, does it impact specific hormones like hunger hormones like ghrelin, or does it not have any impact on them?
Studies are showing that it does still have an effect on ghrelin. They're showing, close to about 30% reduction at 3 months. It's not quite as aggressive as a surgical sleeve or a bypass with those numbers, but it still does lower the hormones that cause you to be hungry. It kind of helps you with satiety and all of those things still.
Wow. Well, that's pretty exciting. You're actually one of the first ones that I've actually heard of doing these, and I didn't realize it until you'd come to our office to introduce yourself, and I was blown away. I was like, oh my gosh, I have never really seen someone do this. But this is a game changer, specifically if you're looking at better quality life for patients with reduced acid reflux, with any of the reduced chances of getting any particular vitamin deficiencies. That's a big deal. Earlier, you mentioned something about a hiatal hernia and how that could be a contraindication or not being able to do an ESG for someone with a hiatal hernia. Would you mind telling our audience what a hiatal hernia is? Because it's a little bit different than your typical hernias.
Yeah, I have a lot of people coming in telling me like, oh, they have a hernia and they'll point to their belly button or they don't really understand what a hiatal hernia is. So hiatal
Exactly.
hernia, or they can say like, oh, I can see it from the outside. A hiatal hernia you can't see from the outside. The diaphragm, or that big muscle that separates your chest and your belly, over time, a lot of patients have these that kind of relaxes that hole that's naturally supposed to be there to allow your esophagus to, so you can eat and things can go from your mouth down to your belly and into your
Mhm.
stomach. That hole opens. And as you're breathing and you take big, deep breaths, that negative pressure that you're creating so that you can breathe pulls your stomach up into your chest. And so many patients have these. They just kind of happen over time. Someone always asks me, like, what did I do to cause this? You didn't really do anything. It's just a natural, fun thing of you that your body has done. And a lot of times you can get really bad reflux from this, depending on how big that hole is and how much stomach hasn't pulled up into your chest. And so if you think about the negative pressure that's pulling your stomach into your chest, well, it's not just pulling your stomach, it's also pulling the acid and the
Uh-huh.
food and everything that's sitting in your stomach that all also comes up. And if your stomach is in the right spot, there's supposed to be a valve that's supposed to keep your esophagus and your stomach separate so that things can go down but shouldn't go back up. And once you've removed that stomach from where the diaphragm is, the diaphragm helps you with that valve. So once it's up in your chest, that valve a lot of times becomes really loose, and so things tend to go up, and people have, bad reflux. Sometimes things get twisted. There's only so much space in your chest, and so things can also get twisted and things don't go down. So then people feel like they get stuck kind of right in the middle of their chest. They'll say, "Oh, when I eat, I feel something stuck right here," and then I
Mm.
wash it down, or eventually it'll kind of fall down, and I can feel it when it does that. And that's another sign that you could have a hiatal hernia.
Now, hiatal hernia is, I'm a primary care physician, and I see these occasional CT scans that they get done for random reasons, not just for a hernia, but it could just be for something else. But all of a sudden, on the final reading, the radiologist will say tiny or small hiatal hernia noted. But is a hiatal hernia mostly diagnosed just through endoscopy, or could you also diagnose it officially by a CT scan?
I use both, and so you can use a CT scan can certainly tell you that you have a hiatal hernia. It
Hmm.
doesn't give it a good idea of maybe how much. You can see some of that it's up there, or really how much it's affecting patients. Like I said, it can be a pretty small hole and only a little bit of your stomach is kind of pulled up. Patients don't ever notice the difference. And so those
Hmm.
don't really need to be fixed or anything like that. But with endoscopy, I can get a better idea of how big that hole is. So is it a big hole? And I can see a lot of the stomach is up there. And sometimes if the hole's really big, I can't tell anything because the hole is so big I can't even see, if there's any narrowing where there shouldn't be, of where I should be able to see the diaphragm. But we do both. So I look endoscopically, I do EGs on most of these patients, just to have an idea of kind of what I'm getting myself into. So I have an idea of what I'm looking for. And
Hmm.
then a lot of them either, like you said, they get a CT for whatever reason. They have belly pain of unknown, whatever, and says small hiatal hernia, or there's a large one because sometimes you can also get colon, or I've seen liver and pancreas all the way up in the chest when these patients get really big ones. That's not very common, but you can end up with a pretty big hole there and have other organs going up into your chest.
Hmm. And are the complications for hiatal hernia surgery more significant compared to like your other typical and other hernias?
They're kind of different complications. I mean, we're not really thinking about having bowel obstructions or things like that. They do sometimes come back, which is kind of the big one that we always think about with hernias, like how long is this repair going to last? And what I kind of tell patients is the muscle is already weak and made whole. So I can fix the hole that it's already made, but I can't make that muscle stronger so that it doesn't make a bigger hole and that it doesn't come back. So them working out and doing things like that can try to help strengthen that muscle and try to strengthen the repair. But I can't make the muscle stronger. I can't make it not have whatever caused it to have a hernia to start with. And then really the complications for this are there's a small risk if you think about I always tell patients that there's like little adhesions that are keeping the stomach up into the chest. So I kind of take down those adhesions, but this is also right up next to the lung cavity. And so I
Mm.
try to stay away from the lungs, but that we call it pleura, or the lining that separates the lungs from where the hiatal hernia is. There's a possibility that I could get into that. Most of the time, I'm able to just put a clip on that, close the hole, and you would never know the difference if I did it or not. Sometimes that hole can be big enough, or air or the CO2 that I'm using to see up into that can get big enough that it causes problems breathing and causes problems with the heart. And that would mean putting a chest tube in. I've never had to do that, but it is a theoretical risk that I tell patients could
Hmm.
possibly happen. Most of the time, patients never know the difference, but it is a theoretical possibility. I've heard of one person having to do that in all of my time, but like I said, I've never had to do that. And then there's two nerves that run along the esophagus. And so we want to make sure we don't injure those nerves. It can injure, cause gastroparesis, cause the stomach not to function like it's supposed to because those nerves help make the stomach push and the end of
Hmm.
the stomach, that valve there to open. And so we tried, our best to not injure those. And normally we're able to do a pretty good job. I've never had to go back and do a different surgery because that happened.
Man, okay, well, thank goodness. Okay. No, but I think the thing is hiatal hernia can be very significant, specifically regarding the symptoms, and a lot of times people don't really know what's causing it unless if they actually get some kind of incidental imaging or undergo an endoscopy, and then they're like, oh, wow, I just had an endoscopy for routine GERD, and I found that I had a hiatal hernia. And so I don't think the general public really knows a lot about them compared to your other hernias, but it's something that, like you said, anyone can get it as we get older, and there's not really one thing that they have done to cause it by any chance. So I just wanted to thank you for going over what a hiatal hernia is and how to treat it. Moving along, one of the things that I wanted to talk about today is specifically bariatric surgery, and then why some patients in my practice that I've noted tend to end up needing revisional bariatric surgery.
Yeah, revisional bariatric surgery is kind of the fastest growing piece of bariatric surgery at this point, especially with the GLP-1s. But there are many reasons that patients could need a revision of their bariatric surgery. It might be a sleeve patient that understood that there's a chance that they could get reflux, and now they have reflux and it's really bad and it's affecting their lives daily. If you think about, I tell patients, we're going to take this big floppy stomach and we're going to make it a tight, skinny tube. And so things tend to go up. It's a high pressure system, and that's just unfortunately how things work. Some patients don't get it at all. I quote patients 15 to 40% will get reflux after a sleeve, and 5% of those patients will have to have surgery because their reflux is so bad. And it's a known problem. And so there's a couple options you can do. Generally change patients to a bypass after that because we're disconnecting where the stomach makes acid from the esophagus, so they won't have reflux anymore. It might also be that patient, same thing. It's just like heart disease. It's a continuum of disease. And so maybe you lost weight in the sleeve, and then 4, 5, 6 years later, the disease that caused you, or the causes of your diabetes and your obesity, have continued and progressed. And so it's not that the sleeve didn't work or whatever, it's just the nature of the disease. And so we need to either revise the sleeve. I can do that now endoscopically. So I can suture and make your sleeve smaller. Some people call it a revisional endoscopic sleeve gastroplasty, a sleeve and a sleeve. There are a bunch of different names out there, but really we're just trying to narrow that lumen again. The stomach will stretch out a little bit over time, but generally that's not patients' problems. It's just the nature of their disease or change it to a bypass, or you can even change it to a SATI, just depending on how much weight loss or whatever the reason is that a patient wants to have a revision.
Well, no, definitely. We'll touch base here later in our conversation about GLP-1s. But, in addition to bariatric surgery, you also specialize in what's known as foregut surgery. And I was wondering if you could tell our audience a little bit about what foregut surgery really entails too.
So foregut surgery to me is kind of everything from the duodenum, or the first part of the small intestines, all the way up to kind of the esophagus and everything in between that. So I deal with stomach diseases. So if you have gastroparesis, or that your stomach just isn't pushing food down like it's supposed to, there are options to help treat that. And that's what I do. There are a disease at the very first part of your small intestine. So if patients have problem with foods going through the first part, or SMA syndrome, you can do a bypass to help with that. And then also the hiatal hernias are kind of the main things that I think about as foregut surgery.
Now, do you feel that in the United States that bariatric surgery and foregut surgery are underutilized? And if so, why do you think they're underutilized?
I would say there's no question that especially bariatric surgery is underutilized. And then foregut surgery, I think, is also underutilized. With foregut surgery, a lot of patients, you go to your doctor, you tell them you have reflux, and your doctor says, great, I'll put you on a PPI, and you're going to be on PPI the rest of your life. The medicines have gotten so good that they really don't look for a cause. And our diets, I think, also encourage reflux. And so it's kind of a common issue that our patients face, and it's just something people have. I didn't have reflux for the first time until I was pregnant. And then I was like, oh my God, what is this feeling that I'm having? Why do people do this every day? How do they live like this? But it's just, we are really great at compensating and dealing with things as humans. And you get on your medicine and then you just go about your life. And no one really realizes that you have, acid reflux, or maybe it's that you have gastroparesis, your diabetes got bad and your stomach isn't working like it's supposed to. And so your symptom is reflux. And reflux is this giant umbrella of like any problems that patients feel. And so we're just not looking for issues or causes for their reflux. And as for bariatric surgery, we do about 270,000 bariatric procedures a year in the United States. But really, this is only about 1% of the population that would qualify for bariatric surgery. With GLP-1s, the medicine and the drug companies have done a really great job of promoting that and allowing you to take medication to help you lose weight, and it really becoming mainstream. Before, I would say that people were supposed to be ashamed of their obesity, and it was all your fault, and it was that you were lazy or whatever, that society has put this standard on you. And that's, as we know, not the cause of obesity. Most of my patients eat less than I do. And they have tried to diet, and they've tried to do all of these things to lose weight, and surgery was the easy way out. Or now the medicine, you don't feel like that. Patients feel like it's another medicine I take, just like I take my medicine for my diabetes, I'm taking medicine for my obesity. And that's really what it should be. It's just a part of a part of the medical community and the
Hmm.
nature of our diseases in the United States. So I think that's really helped us. But also, some people are still afraid of surgery. Surgery is a big deal. I always tell patients, this is every day for me. It's not every day for you. And so they should be nervous. And I would be worried if they weren't nervous. But I just would say that to me, I got into this because, like I said, my mom, she was a diabetic. She had high blood pressure. And now she doesn't take any of those. She was on 2 medicines for her high blood pressure and now is on half of 1 dose and now doesn't have diabetes. But the studies, we've been doing bariatric surgery for a very long time. It is the most effective way to help lose weight long term. And it also helps diabetes. It helps heart disease. It helps with your high blood pressure, your sleep apnea. All of those things are proven to have resolution or improvement with bariatric surgery. And so I think we're getting better. And now, as a community of bariatric surgeons, we are trying to push and talk to family medicine doctors, talk to the community, talk to the outside world that, it's not this huge, scary thing that it used to be. And there are all these complications that there used to be. And it can be a really great tool, along with lots of other tools to help patients with
Hmm.
their obesity and their obesity related diseases.
Well, no, I definitely agree. You touched on some amazing points there. Number one, when you're talking about any kind of symptomatic management medically, that the medicines do a good job of masking the symptoms, but you don't really get to the root cause of it. And that's really important. Especially one of the things that I don't think we really look into a lot in primary care is the adverse effects of proton pump inhibitors, specifically omeprazole or pantoprazole, the vitamin deficiency that they can cause, and also decreasing immune system. And in addition, there's also some studies that have shown perhaps some concern for increased risk of dementia with prolonged use of PPI. So it is something to definitely look into. But you also brought up really well the advent of GLP-1s and how they really have kind of changed the game to some degree. And you kind of already touched on this, but do you feel that the GLP-1s have changed the way that bariatric surgery is practiced?
Yeah, we also in our clinic also do medical weight loss. And I think it's lots of tools in our toolbox. And so
Hmm.
GLP-1s can be good for patients,
Hmm.
especially so say you've put in this investment and you had bariatric surgery. Not everyone, I can quote the average person and how much weight you're going to lose, but not everyone does it. It's an average. And so
Yeah.
some people will lose 100% of their weight and some people are only going to lose 20%. And so adding a GLP-1 on top of surgery is a great option. And some patients only need to lose a little bit of weight. So, like me, I'm in the process of trying to lose weight. I just had my second child in 2 years. And so the baby weight has come on and I'm struggling to lose it. And I haven't started, but I've considered adding a GLP-1 to help me kind of get over that bump. I'm older now. And so it's just harder to lose weight, right? No matter if
Hmm.
I'm eating right or not, it's harder to lose weight. And our lives are busy. But I will think that GLP-1s are really nice in the short term, but they can be hard to continue. It's hard to stab yourself once a week with a needle for forever. And studies have shown that, it's hard to do that. So a lot of patients go off at some point, get off the medication for whatever reason. They
Hmm.
can't get it. It's expensive, whatever reason they have to get off of them. And so it's not that we can kind of continue long term at this point. And unfortunately, they have long-term side effects. I have some patients that get gastroparesis. That's part of how the medicine works. It slows down your stomach. You don't feel as hungry. But even when they get off the medication, some people still have those issues and now have to deal with being nauseous all the time. Some people can't tolerate them even to start with because
Hmm.
they cause so much nausea and those kind of things. And then unfortunately, a lot of people gain the weight back once they stop. It works really great, like right now. But once you're off of it, eventually you start feeling hungry again and you're going to start eating again. And so it just doesn't have the long term data to back it up to help you lose weight. But it can be a good option. It's a tool in the toolbox. All of these are just tools to help you treat your obesity.
And I'll completely agree that there is a great need for bariatric surgery. Yes, the GLP-1s are there and they may be a good option, but at the end of the day, bariatric surgery is something you're always going to need when it's necessary. It's not something that people can avoid. And I do think that to some degree While I appreciate the effect that GLP-1s have, and I'm a little biased. I'm on one right now to help me with my weight loss, and it's been good, but it hasn't been without its fair share of struggles. But I do think that we do have to look as a community and understand that bariatric surgery is always going to have its need there, and we can't continue to ignore it. Speaking of which, what insurance barriers do you feel that patients commonly face when it comes to bariatric surgery?
A lot of times it's kind of a yes or no. You either have bariatric benefits or you don't. It's becoming a lot more popular and a lot of people are getting these covered. It's becoming much easier. Medicaid, Medicare all cover bariatric surgery. Even some states are starting to require every insurance to cover bariatric surgery. So in Arkansas, that's a requirement. Every insurance has to cover bariatric surgery. And so I think we'll see that more and more, is that more places, more insurances are covering it. Benefits of it with the diabetes and your heart disease and the problems that you as an obese person will have later on. The benefits of bariatric surgery are a benefit to an insurance company, assuming that you'll be there. So I think we'll see it more and more. The gold standard treatment for reflux is a bypass in an obese patient. And so there are other ways to treat it in a skinnier patient, but the best way to treat it in an obese patient is to do a room-wide gastric bypass. So maybe I need to do your surgery because of your reflux and I'm not doing it for weight loss. That's a unfortunate side effect that I would expect you to lose about 70% of your excess body weight along with, but we're doing it to treat your reflux. And so there are sometimes ways to get around that, or, doing what's best for the patient under insurance's rules. And so we can kind of play with that and make things work, even if patients don't necessarily have bariatric benefits.
Oh, no, that's definitely a cause of concern, especially when it comes to insurance coverage. You have been in this field now for a couple of years, and I was just wondering if you had any words of wisdom for anyone that's looking into going into bariatric and foregut surgery.
Yeah. I would find someone that you're comfortable with. There are lots of bariatric surgeons out there, and there are lots of ways to skin a cat. But you really want someone that's going to invest in you and invest in your program. This is not a have surgery, go home, you'll lose weight in 5 months, you'll be skinny, you'll not have any problems. This is something someone should be following you long term. I have a lot of patients that go down to Mexico or go somewhere else to have these surgeries done, to have them be cheaper, or they go in and find a doctor that's just doing them and not really investing in you long term. And so you really want someone that's going to invest in you long term and follow you and be there if something were to go wrong. If you're
Hmm.
gaining weight down the line, if you get reflux, you want to be able to go back and go see your surgeon, and have them have what's best for you in mind, uh, and be able to do all these things. And so that's my recommendation. Is really get to know your surgeon as much as you can, do things online and find the best fit for you and someone that's going to take what you think and what you're wanting out of the procedure and really base on what they do, as opposed to, being someone who only offers a sleeve. If you only have one tool, you only can offer one option, right? Have hammer, will hit with nail. You want
Hmm.
someone who has lots of tools in their toolbox to really help you find the best fit for you. The best time getting the best results happens the first time. We do a lot of revisions, but to get the best results, you only want to do surgery once. So find the person that's going to help you do that.
Got it. Any words of wisdom for any prospective medical students or people trying to get into medicine that want to get into bariatric surgery and foregut surgery?
Yeah, stick with it. It's a long road. Having just finished the long road, I would say a lot of people tried to talk me out of surgery. I
Hmm.
do some like women in surgery kind of talks. Everyone tells you it's this big, bad, scary thing. You're going to work a ton. You're never going to have a family. I had 2 kids already. I had one in residency, one in fellowship. And, you can make things work and make the schedule what you want it to be. So hang in there, even if people are trying to push you out, trying to tell you it's not an option, that you're going to have a terrible life. I think most of us at this point don't want to live like that, and have found that surgery can be very accommodating to what you want. I don't start my procedures at 7:30. I don't start my procedures till 8:30 because I have to take my kids to daycare.
Hmm.
And so you can make this what you want it to be. You just have to stick it out through residency and fellowship. And there is a light at the end of the tunnel. I have finally found it, but the light is there. You will get there eventually.
Yes. Yeah, and that's what I've always kept telling myself during medical school and residency is there is always light at the end of the tunnel. And it's there. I'll have to admit, medicine is very rewarding and it's a difficult task, not going to lie. There's been pretty good number of setbacks, but like you said, stick with it and you will see the light at the end of the tunnel. Well, Dr. Sheppard, thank you so much for taking your time, answering all of our questions and really going over the importance of bariatric surgery and foregut surgery. I really appreciate it. And we would love to have you on again down the road. But once again, thank you so much.
Yeah, thank you so much for having me. We at OU Health are always happy to help patients and would love to see anyone that wants to come by and say hi. And I just appreciate anyone listening to me ramble.
Today was one of the most informative episodes we've had because not a lot of people out there really understand what bariatric surgery is and the importance of it. So we definitely really enjoyed you helping us understand bariatric surgery and foregut surgery more. So thank you so much.
Thank you.
If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway and a review. See you next week.